To Grand Rounds this morning. I'm going to begin as usual with our land acknowledgement to remind us that Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. And I'm delighted to present our series of speakers this morning. I call this an Ellen Goldbloom Roadshow because this is a number in a series of presentations that Ellen has brought us on how to actually get full value and academic knowledge from our electronic health record and digital tools. And this is another one of those in that series. So I'm going to present, we have 4 speakers for this morning. I'm going to start with Ellen Goldbloom, who will be leading off, and then present the others. I'm not sure which order they're going to go in, but they will let us know as they proceed. So Ellen is known to probably everyone here. Ellen is a pediatric endocrinologist with research, leadership, and QI interests in transitions from pediatric to adult diabetes care. As well as delivery of care, including the adoption and optimization of electronic medical records, securing patient portals, and virtual care. Her CHEO leadership roles include Deputy Chief Medical Information Officer and Medical Director of Ambulatory Care. Next, we have Catherine Dulude. Catherine is CHEO's Embedded Human Factors Practitioner. I like that title. She applies human factors and design research methods to optimize clinical care, provider workflows, patient-provider interactions, and patient, family, and healthcare provider experiences. She participates in safety investigations, workflow, process, and space redesign challenges, of which I'm sure there have been many, and works with frontline staff and multidisciplinary teams to understand requirements and design solutions. During the pandemic, Catherine focused a great deal on rapid development and supportive virtual care services. Our third speaker is Dr. Leanne Zweep. Leanne is a mom to a 12-year-old boy with Russell-Silver syndrome, a rare and complex genetic growth condition. As you can imagine, her son has been a patient in a variety of specialties at CHEO, including endocrinology, GI, genetics, ENT, developmental pediatrics, nutrition, cardiology, emergency care, surgical care, and inpatient care. She joined us as a CHEO family leader in 2019 and also sits on the Waldorf Care Family Advisory Committee. Professionally, Leanne is a principal researcher with Statistics Canada. Her areas of expertise are population health data and healthy child development, with a specific interest in the health of vulnerable children and youth. And finally, we have Dr. Shelley Vanderhout, who is a registered dietitian and postdoctoral fellow at CHEO and the University of Ottawa. Her work focuses on patient and family engagement in child health research, learning health systems, and developing research methods that are oriented around patient and family preferences, values, and priorities. The title of their presentation today is virtually the same, Evidence-Informed Virtual Care at CHEO and Beyond. So without further ado, I will turn it over to Dr. Ellen Goldbloom. Ellen, over to you.
Thanks, Mona, for those introductions. It's my pleasure to be here to speak along with my colleagues who you've introduced, and also on behalf of the larger virtual care evaluation group, who you'll meet soon in an upcoming slide. In terms of our disclosures, I am co-investigator for a Medtronic study using insulin pumps, and also a member of the EPIC Pediatric Endocrine Steering Board, and those are unpaid positions. And my colleague Shelley is supported by a CIHR Health System Impact Fellowship Award. Next slide. So some of you may remember that we were here just under 2 years ago, some of the same presenters as well as some others, talking about how we implemented the state of virtual care in pediatrics and how we implemented at CHEO. And we gave a little bit of a teaser that we were starting to do some work in terms of virtual care evaluation, and that we would be back. And so that's what we're doing today, to tell you where we've come with respect to virtual care evaluation. So we hope that by the end of this presentation, you'll be able to describe the current state of evidence regarding evaluating pediatric virtual care, recognizing the existing gaps in evaluating pediatric virtual care, and the importance of a comprehensive evaluation. We hope that you'll understand the conception and utility of a homegrown pediatric virtual care evaluation framework, and also understand how to identify, develop, and integrate evaluation metrics into virtual care delivery to support continuous quality improvement. Next slide. So we're all aware by now that certainly virtual care did exist before the pandemic, but then the pandemic came and really pressed fast forward on where and how much virtual care was being delivered. And this is certainly one of the silver linings of the pandemic. And I say silver linings because there are so many benefits that we've, I think, seen as providers, maybe experienced as patients. So there's improved convenience, both for families and patients, but also for providers, improved patient and family experience and cost savings, just to name a few. There are also some, unique benefits and advantages, like the value of seeing a patient and their family in the comfort of their own home, in their natural habitat, almost like a home visit. But with those benefits come limitations, of course, the most obvious being the lack of the physical exam. And in pediatrics, we also need to think about adolescent confidentiality. So something is lost in the virtual space when you don't have that closed door with an adolescent patient, for example, having a confidential private conversation. It's harder to do that in the virtual space. Access is often cited actually as a benefit because it can improve access, but we also need to make sure that we're not increasing the digital divide when it comes to, digital literacy and access to Wi-Fi or data, for example. And so although virtual care uptake has increased and there's been lots of documentation of the benefits and limitations of that, we're really lacking in terms of comprehensive evaluations of virtual care delivery. And what that means is that it makes it more difficult to know exactly how to integrate virtual care into the way we do business, so into the way we deliver overall care. Next slide, please. So just zooming into where we are at CHEO and how we've implemented at CHEO, and then we'll go into evaluation. So as we focus on our experience at CHEO, we really did come out sort of upfront as a leader in virtual care. And we were thankful that we had the opportunity actually before the pandemic to pilot home video visits in a few specific areas, namely mental health and endocrinology, through the Ontario Telehealth Network program or platform. And that allowed us to do some pilot evaluations and really work through the kinks. And so what it meant that when March 2020 came, we were able to really hit the ground running and convert very quickly to primarily video synchronous virtual care. And we very quickly stood up programs in all areas of the hospital. And this infographic on the right just shows you an overview of the types of virtual care happening in various areas of the hospital. And I just want to point out here that often when we think of virtual care, we think of the synchronous form where the provider and the patient are together in the same virtual space, but it's important to recognize that the definition of virtual care actually also includes asynchronous virtual care, which would include things like secure MyChart messaging or e-consultation between providers. Next slide, please. So as we implemented, sorry, the slides are a little blurry, but don't worry about being able to read this. I just want to give an overview to show you that as we implemented, we realized how important it was to really track where and how, if and if not, virtual care was being provided in different areas of the hospital. And so with the leadership of our CHEO eHealth and IS team, we were able to create this dashboard, which really nicely tracks virtual care throughout the hospital on a real-time basis. And so what we saw with this is that, when March 2020 came, we had a huge conversion to primarily virtual care, up to 80% overall. And then things stabilized over the first year or two of the pandemic to about 40% virtual care. That has since dropped as restrictions have eased, but we certainly are seeing virtual care continue, and particularly in some areas like rehab and development and mental health, where they've sustained a very high proportion of virtual care. The other thing that is highlighted in this dashboard is that we divvy out telephone versus video visits. And what we can see is that we've sustained a high proportion of video versus telephone visits. And that was done on purpose because we really prioritized and valued video as a form of virtual care because we felt it was probably higher quality. And also we felt that it would be like more sticky and sustainable. And certainly new billing rules that have come in more recently have shown us that video visits are remunerated or valued more than telephone visits. And so next slide. And so we've had the opportunity to network and collaborate across the country and also internationally with respect to our pediatric experience at CHEO within the pediatric space and also beyond. In this paper in Pediatric and Child Health, we were able to summarize some of the innovations that happened at CHEO to support virtual care in the emergency department, in inpatient medicine, in outpatient ambulatory care, and also in mental health. And we were able to bring together sort of a list of facilitators that allowed the success of implementation and also the sustainability. What's been missing here is, although there were some unique evaluations going on, is we don't talk a lot about the ongoing evaluation. Certainly, there have been some wonderful quality improvement and research projects in different areas of the hospital, including the emergency department, mental health, neurology, asthma education, inpatient medicine, diabetes. I'm sure I'm missing some, I'm sorry. And there have been some really useful results that have certainly guided the way we have continued to sustain virtual care. As an example, in diabetes, through our quality improvement evaluation, we've actually changed our care model in that we ensure that we have one patient visit per year for youth with type 1 diabetes that is in person, but the other 2 to 3 visits per year can be either virtual or in person, depending on things like appropriateness and patient and provider preference. So although these evaluations have been excellent and have certainly guided the way we do things, they've been a little bit difficult to, well, first of all, they're primarily focused on the individual experience, not all of them, but primarily, which is certainly important, but it's not the only thing to measure. And also, because there aren't great validated tools out there, we all asked questions differently and measure things differently, which makes results a little bit more difficult to synthesize and therefore a little bit more difficult to integrate into the way we do things. And so with that, I'm just going to hand over to Shelley to talk more about the importance of evaluating virtual care in a systematic way.
Thanks, Ellen. So in order to implement virtual care, both within CHEO and more broadly across other health systems in Canada, there are tools available as shown on this slide from the Health Standards Organization, Healthcare Excellence Canada in partnership with the Canada Health Infoway, the Canadian Medical Protection Agency, and the College of Physicians and Surgeons of Ontario. And these are just a handful among other resources. Now, while these are excellent examples of general guidance around how to approach virtual care, for the most part, there isn't enough evidence available to robustly inform them. Therefore, gaps remain when it comes to understanding outcomes of virtual care and navigating evidence-based virtual care post-pandemic, that is, when it's not mandatory, but still may be preferable. So to that end, while it's clear that virtual care was certainly accelerated by COVID-19, what's next is evaluation towards high quality, appropriate, and safe care that meets the needs of patients, families, and providers. So it's worth digging into the rationale for evaluating virtual care. First and foremost, we know that patients and families have expressed preference for virtual care when it's appropriate. And in particular, those with young children cite reasons such as convenience and time and cost savings. It's also obviously very important to ensure that the care we're providing is safe, appropriate, and effective. And it's an added bonus when we can provide evidence for funding and resource support. We also need to ensure that our health systems can sustain integration of virtual care beyond the pandemic once we establish where it can be continued. And of course, focusing on continuous improvement towards the quadruple aim is always a priority. So that is striving to achieve better patient and caregiver experiences, population health, the work life of providers, and lower healthcare costs. So we do have some tools and resources available to guide evaluation of virtual care. So there are recommendations from Health Canada about ensuring equitable access to virtual care, as well as from the Canadian Institute for Health Information for measuring quality and accessibility of virtual care. In terms of validated measurement tools, we'll touch more on this later, but the landscape is a little bit more sparse. So there are a few commonly used and validated tools, such as the telehealth usability questionnaire shown here and the telehealth satisfaction questionnaire, in addition to a more locally developed experience survey, which is not validated to our knowledge, from the Association of Family Health Teams in Ontario. However, these are all focused on experience, like Ellen just mentioned. And so despite many other outcomes that could be evaluated, and oftentimes we found that these types of surveys and questionnaires tend to be tailored or modified to suit their specific clinical context or patient population, which not only can render their validity, but it also makes scalable evaluations and data synthesis across health systems and time challenging, if not impossible. So before we jump into how we are filling this important gap at CHEO, there is one key resource available that is worth noting and helps springboard our work in comprehensive virtual care evaluation. So the SPROUT, or Supporting Pediatric Research on Outcomes and Utilization of Telehealth, it's a bit of a mouthful. This network is a branch of the American Academy of Pediatrics, and its purpose is to create telehealth research frameworks and resources, as well as provide education around virtual care and sustain a database for telehealth research. So in 2020, SPROUT created a framework called STEM. So that stands for the SPROUT Telehealth Evaluation Measurement Framework, which was developed based on recommendations and guidelines from the National Quality Forum, the World Health Organization, and the Agency for Healthcare Research and Quality. And it includes 4 domains shown here. So those include health outcomes, health delivery, individual experience, and program implementation. So with this framework in hand, we saw an opportunity to build upon it to support clinical and program leaders in planning and conducting their own virtual care evaluations. So Catherine will touch more on this later, but some of the limitations of this framework that we thought we could build upon were, first, flexibility for use both in research and quality improvement environments, as well as making it adaptable across various stages of program development, from the beginning in the planning stages, as well straight through to the end for implementation, monitoring, and improvement of virtual care. So I'll hand it back over to Ellen.
Thanks, Shelley. So with all of those resources in mind, we felt that that was helpful in terms of guidance, but we felt that there was still a gap, and we really felt that we needed something to help us that was more practical, accessible, and relevant to our CHEO community to really guide us in evaluating pediatric virtual care. So with the support of CHEO and the CHEO RI, and sponsored by our Chief of Staff, Lindy Sampson, and the CEO of the CHEO RI, Jason Berman, and also with the support of our IS team and the virtual care leadership team, we developed the virtual care evaluation group. So next slide. So we brought together this group with representation from all of these areas listed here. And the idea of this group was to develop an evaluation structure, and that can mean different things, which we'll review over the next several minutes, that aligns with the CHEO RI strategic plan and is integrated in CHEO's operational goals. So we brought together several stakeholders and partners to form this group with, again, representation from all of these areas. And within each of our members, we had some really neat niches. We have some really neat niches of expertise, including expertise in medical education, social determinants of health, human factors, digital care. And so if we go to the next slide, I'm not going to list through everybody, but hopefully you'll see some familiar faces here. So these photos make up our virtual care evaluation group. And so hopefully you can see that it's a diverse group of people with lots of expertise in different areas. I also want to highlight, not shown here, we also had the help of Jim Bottomley and Lisa Snidel as we started to get going, and they were really helpful in terms of our project management and coordination. And also thanks to lots of people who provided consultation advice as we got this going. And so together, we've worked together to work on some of the things that you'll hear about in the next several minutes. I want to highlight that a critical member to this group is the patient and family voice. And so bottom right there, you can see Leanne, who is our parent representative, and I'm going to hand it over to her so that she can talk to you about the perspective of the importance of this work from the family voice.
Great, thank you very much. And I want to say thank you to the team for including me as a representative to the virtual care evaluation group. I know I feel very fortunate to have a voice within this team, and I think it brings a unique perspective. So I thought I'd start just by telling you a little bit about myself. And I know there was a little introduction at the beginning, but I am the mom to a 12-year-old boy who has a rare condition known as Russell-Silver syndrome. The condition has given us the opportunity to meet people in all kinds of different departments at CHEO, and certainly his complex care leads me to call us frequent flyers, because we've been a part of most clinics and departments at CHEO over our time. And you'll see on the top there, I always put pictures of my cute son from 3 pounds at birth all the way up to his now hockey career going towards the NHL. So why did I become a family advisor? Well, what I really wanted to have an opportunity to give back. I know we've had lots of up and downs over our period with the hospital, and certainly we've had some successes along the way and challenges along the way. And I really wanted to have the opportunity to use those experiences to give back to other families. If anybody can gain from the perspective that we've had, I think that's a real win. And I do feel like, you know, I have a background in child development, in research. I have a lot of support from our families. I have financial stability, and yet I still struggled with our journey. So I can only imagine how families with not all of those advantages would deal with the system as they were trying to navigate with a sick child. So I really see a big responsibility for me to be able to help those families. I'm very passionate about helping people and in providing the family perspective. I know it's very different perspective from the way that a clinician might view care and navigating through the system. And so I try to always bring that perspective. In terms of the value of virtual care for us, certainly we've seen a lot of changes since we started our journey in 2010, both in terms of, you know, at that point, there would have been no synchronous or asynchronous virtual care. And now that's become a big part of our journey. Generally, it's been a very positive experience. For a lot of things, we can use virtual care, but there are also a lot of things we can't. And that sort of goes with the types of care needs that my son has. We live in a rural area, so you know, having the virtual option saves me probably, for a 10-minute appointment, it probably saves me a half a day of time and resources. So obviously virtual appointments are useful when possible, but I think have always said the need always has to match the type of care that is received. So for some families, what I feel would be an appropriate virtual appointment would not be the case for another family who really needs that face-to-face contact. So it's very personal in terms of the way that virtual care can fit into a larger perspective around care. And I'm going to turn it over now to Catherine.
Thanks, Leanne. So we're so fortunate to have Leanne as a part of our team to help us with the first big piece of work, which was developing a framework for evaluating virtual care. And of course, she's still on the team, and all of the team members that Ellen introduced a minute ago did participate in this first piece of work, which was developing a framework for evaluating virtual care. And we did this with a vision that this framework would facilitate a standardized approach to virtual care evaluation across CHEO and hopefully other centers as well. And that this standardization would support data synthesis and evidence-informed decisions about virtual care program development, continuous improvement, both at the local level and also across multiple programs and organizations. Next slide, please. The methods that we used to develop the framework started with literature review and existing framework review, some of the results of which Ellen and Shelley have already shared. And then we moved into using consensus development panels involving the whole virtual care evaluation group. And finally, once we developed a framework, we piloted it with the type 1 diabetes clinic to make sure that it was practical. So in the next slide, I'll go through in more detail the development and evolution of our virtual care evaluation framework. So you can see on the left, we started by forming the team and the literature review, as previously mentioned, and discovered the STEM framework and saw a real opportunity to build on it. So using the STEM framework as a guide, our aim was to develop a comprehensive framework to support standardized approach to virtual care evaluation across a variety of programs. And we further aimed to create a virtual care evaluation framework that was flexible for use both in research or quality improvement contexts and at various stages of program development, from planning through implementation, monitoring, and improvement. And that's really where we felt there was an opportunity to build on the STEM framework and evolve it to be more detailed and specific in terms of guidance for folks evaluating their own virtual care programs. So the first thing we did was to get all virtual care evaluation team members to critically appraise and review that STEM framework and approve it as a starting point to populate the domains and subdomains of our framework. And then the consensus methodology I mentioned, what we did was we started with the 4 STEM framework domains: health outcomes, health delivery, experience, and program implementation and KPIs, and divided our larger team into smaller subgroups to generate evaluation questions, measures, and data sources for each of those 4 domains. These smaller consensus development panels were composed based on interest and expertise. We also ensured that each consensus development panel had broad representation from a diverse set of clinical areas. This was a really iterative process, alternating between meeting in smaller consensus development panels, and that was really focused on developing framework details and digging in to questions and sorting through what should be included under each domain. And then we also met as a larger group to discuss and develop consensus on domain definitions and scope. The process overall was guided by 2 members of the team with expertise and experience in evaluation methodology. And during that iterative process, the team also cross-referenced other evaluation frameworks, including Ontario Health Quality, the COMET Outcomes Classification, Canada Health Infoway Benefits Evaluation Framework, and other work on evaluation of telehealth usability. We also discussed and reached consensus on appropriate settings and contexts for which the framework could be used, and clarified the intended audience, which we felt was, while initially focusing on CHEO, the intended audience really grew to be broader than our organization and individual program owners. So once each of our consensus development panels reached consensus on the scope and examples within their domain, the entire evaluation framework was reviewed and revised by all team members to gain consensus on final content. And then, as I mentioned previously, as a final step, once we had that framework in hand, we applied the framework to an existing virtual care program at CHEO, which was the Pediatric Type 1 Diabetes program. And we did that to assess real-world applicability, consistency, and also to illustrate practical use of the framework. And so that initial test was done by 2 pediatric endocrinologists who used the framework to specify and contextualize the evaluation questions, measures and indicators, data sources, and comparators within each domain and subdomain to create an evaluation plan that was relevant for their population. The next slide, please. So this is the final framework. It has 4 measurement domains that parallel STEM, health outcomes, health delivery, individual experience, and program implementation. And under these 4 domains, we have specified 19 subdomains and provided a structure in an Excel spreadsheet-based tool that can readily support development of organization-wide or program-specific evaluation questions. And we've also provided example questions that illustrate scope of each subdomain and associated measures and data sources and basis of comparison for each. And so that's where we've really gone beyond what was presented in previous frameworks. We have submitted a manuscript for publication, which you can access at the QR code on the slide. And that manuscript describes the framework, defines domains and subdomains, and includes that Excel tool in the form of an evaluation matrix. So within the manuscript and tool, we provide guidance on how to implement the framework, including developing SMART aims, following quality improvement methodology, determining evaluation questions for each domain that speak to the objectives of the virtual care program in question, and identify measures that can be used to answer questions, evaluation questions, their data sources, collection strategies, and bases of comparison that can be used to determine success. Next slide, please. Oh, no, thanks. So this is a snapshot of the tool, just showing one domain of that Excel spreadsheet. And so you can see the framework is presented here, the health outcomes domain, and is then subdivided into subdomains of physical, mental, and behavioral and quality of life. And for each subdomain, there are a representative set of questions. And for each question, measures, indicators, data sources, data collection strategy, and so on. And so that this tool is designed to be a guide that leaders or clinicians could use to develop their own program-specific evaluation questions. The proposed evaluation methodology structured within this framework supports and expands on previously published virtual care evaluation frameworks, as I mentioned previously, really by providing that additional detail, including those subdomains. We believe is widely applicable and can be used to evaluate a range of pediatric virtual care programs in a standardized manner to help fill that gap that Ellen and Shelley described previously. And that the application of this comprehensive yet easy to use framework will inform appropriate implementation and integration of virtual care into routine practice and support sustainability and continuous improvement. And so at this time, we did that one small pilot as part of the development of the framework. We've now received funding from Healthcare Excellence Canada to pilot the framework further, and are working with a number of programs within development and rehabilitation at CHEO to do so. So that was really the first big piece of work that the virtual care evaluation group completed. So now I'll hand it back to Shelley to share some of the other work that we've been up to over the last 2 years.
Thanks, Catherine. All right, so switching gears a little, we're now going to share with you some of the other research that the virtual care evaluation group has been doing at CHEO. So the first study is an environmental scan we conducted to understand how experiences with virtual care have been evaluated across Canada in pediatric settings. So in terms of the background for this study, we know that understanding the experiences of those who receive, deliver, and coordinate virtual care is essential to its sustainable, high quality, and patient-centered implementation. So ideally, we'd like to develop a harmonized approach to virtual care evaluation, especially in terms of its the experiences that people have with it. And in order to get there, we first thought it was important to describe current and completed evaluations that are happening both locally and across the country. And just a note, similar to our previous slides, you can view the preprint of this study at the bottom of the slide. So the objective of this analysis was to describe strategies used to evaluate experiences of virtual care in Canada, both from the patient and family and provider perspectives. And to do this, we conducted an online survey and individual interviews with clinical, research, and operational leaders delivering and evaluating pediatric virtual care in Canada. In terms of our results, we were able to identify 15 unique virtual care evaluations, which measured the experiences of parents or caregivers, children or youth, healthcare providers, and as well some support staff. And there was some overlap there, which is why the numbers don't all add up to 15. 2 respondents used validated tools, and the remainder modified either existing tools or developed their own to suit their specific context. So in terms of the most common questions that were included in people's evaluation, we identified that overall satisfaction was very common, as well as questions about comparison of virtual to in-person care and whether virtual care would be selected again in the future. But most importantly, we identified that respondents really expressed that a standardized core set of questions to evaluate experiences with virtual care in the future would really be helpful to streamline and make their evaluations a little bit not only easier, but also more impactful. So I mentioned a few slides ago in the background, identifying this was really the goal of this study. So all of the findings that we have from these surveys and interviews will inform our next steps in developing an evaluation tool that can be used across contexts and hopefully make data synthesis and comparison easier in the future. Another study that we're just in the process of launching is a Canadian Pediatric Surveillance Program, or a CPSP study, where we're looking to identify adverse events potentially related to virtual care among children. So with the lens that we'd like to promote safe, effective, and appropriate virtual care for children, we know that it's important to identify where virtual care may actually not be the best option. So due to some of its limitations, like a lack of ability to physically examine a patient, adverse outcomes such as an incorrect or delayed diagnosis is possible. And currently there's no system to track and document these events in Canada. So therefore, the objectives of the study are to understand the burden and nature of adverse events where they may be happening due to virtual care among children in Canada, and then go on to describe these types of adverse events that may be happening and any association between clinical and child characteristics and the risk of these adverse events. So in order to do this, through established infrastructure of the CPSP program, which is grounded in both the Canadian Pediatric Society and the Public Health Agency of Canada, its members are actively surveyed monthly for a handful of rare but important events. So we'll ask just under 3,000 pediatricians and pediatric subspecialists if they have observed any adverse events possibly related to virtual care using these methods. So our broad and rich expertise in our co-investigator team, which spans across Canada and really has roots in so many different clinical specialties, helped us to define how we would characterize adverse events in this study. So we considered a wide range of different types of adverse events that could potentially play out as a result of virtual care. But we decided that the highest quality data would probably come from just selecting a handful and going with those. So in the end, after much deliberation, we decided to define adverse events in this study as wrong, missed, or delayed diagnoses, or an emergency clinical or social situation where a provider is not able to administer timely care. So respondents to these monthly email surveys will be asked if they have observed any type of adverse event that they suspect to be related to virtual care according to these inclusion criteria. And then if they have, they'll be asked to describe child characteristics, sociodemographic information, and medical history, as well as all of the details of the adverse event and its causal factors and management. So ultimately, we hope that this study will inform guidelines for safe and effective pediatric virtual care, as well as help families and healthcare providers decide when and for whom virtual care is appropriate. Okay, so as we near the end of our presentation, we're just going to turn it back over to Leanne to give us a bit of her perspective about why virtual care is so important to families anyway.
So yeah, thank you very much. And I think previously I spoke a little bit about virtual care and how we've used virtual care, but I think one of the key elements is why is the actual evaluation of virtual care important for families. And as I said before, for us, There are certain appointments that for which this is a great option. You know, I can think of things like needing a med refill or, you know, just needing a little check-in. Sometimes those are great options to be able to do a virtual care appointment. But sometimes, you know, we need to be in person. And I love having that flexibility. But I also know that having the evaluation of whether or not that is the best way to do care is also really important to families. I know that from my research background, obviously evidence is key for things like policy development and funding sources and things like that. So, you know, having the information available to evaluate the efficiency or effectiveness, or, you know, whether or not this is an appropriate way of providing care, it is really important. And I particularly wanted to point out the importance of how this is perceived by families. So my assumption as a parent is that this kind of evaluation is taking place. I just assume that nothing's going to be missed due to the nature of virtual care, and that, you know, it's not just a matter of convenience, but also a level of trust that is existing between a family and the care that they're receiving, in knowing this is something that we know is an appropriate and effective way of providing care. So as a family, you know, there's a lot of discussion within families about, you know, whether or not it's virtual care is an appropriate way of receiving care. Certainly very polarized. I hear other families talking about, oh, it's great because it's flexible, and other families saying, oh, it's not so great because, you know, things might get missed. And so obviously it's a very personal situation on whether this flexibility is a good option, but it's also important that families have that level of trust in the care that they're receiving, and knowing that the provision of care in these formats is something that has the confidence of providers, of government resources who are just making decisions on, you know, whether or not this will be funded. I think it's really important for families to know that virtual care is a flexible option that has the evidence to prove that it is the best way of providing care. So I'll turn it back over to you, Shelley.
Thanks so much, Leanne. Such an important perspective. So just in conclusion, we know that virtual care has an important role in children's healthcare beyond the context of necessity during the pandemic. And so we think it's the right time right now to evaluate virtual care for its efficacy, appropriateness, safety, and patient and provider centeredness, to understand how to implement scalable and evidence-based virtual care, both in our own center and across other centers. So the Virtual Care Evaluation Group will be continuing its active research and quality improvement projects, such as piloting our framework in rehab and development, as Catherine mentioned, as well as conducting a scoping review of virtual compared to in-person pediatric care interventions. And you can stay tuned for that, as well as a CHEO.net virtual care page, which is coming soon, where you can view and have access to all of the resources that we've mentioned in today's presentations, as well as all of the research, such as preprints and hopefully published manuscripts coming soon. So all of that will be made available on this CHEO.net page, published soon. So before we turn to Q&A, we'd just like to acknowledge all of the members of the Virtual Care Evaluation Group, as well as the CHEO-RI Patient and Family Advisory Council, and all of the other supporters of this important work listed on this slide. So thank you so much, and we welcome any questions.
All right, fantastic presentation, really great collaborative effort there, and it's really wonderful to see what you've created in this really short period of time on evaluating virtual care. So you've left us with a good amount of time for questions. Thank you for that. And I see Dr. McKenzie's put his camera on. Go ahead, Alex. Please.
Okay, you might as well get me out of the way early on here, Mona. A wonderful, comprehensive presentation, guys. A totally different tangent. Ellen, seeing that you're the chair of this EPIC Endo group, could one, in addition to this meticulous approach, also just look at visits for type 1 diabetes, virtual versus face-to-face, and then just ask 3 months later, A1C delta. That basically, if this will never happen because of all of the ethics, but if you can get hundreds, potentially thousands of visits across North America and just bin them at virtual versus face-to-face, and see if in general A1C goes up or down. Very, very stupid question, but if you get large numbers like that, there might be something there.
Yeah, no, I think that's a great question, and I'm blanking on the name of the EPIC module that does exactly that. Somebody from EPIC can type in the chat what it's called, but it is a way that it can pull together all of the big data from all areas and ask those, as long as things are captured in a systematic way, which things like A1C and visit platform in person, visit type, Cosmos. Thank you, Jim. It's called Cosmos, where you actually can pull that data. And so absolutely, I think that's, we have a steering board meeting today, so I can actually.
If you could do that and get back later on this afternoon.
Yeah, no problem. Okay. Yeah, no problem. I'll do that. But actually, a tangent to that, to the answer to that.
My tangent. That's an outrage.
On a smaller scale, and we talked about one of our objectives being like thinking about integrating, in a prospective way, the evaluation component as we deliver the care. And actually, when we did the quality improvement study in diabetes, unfortunately, it was at a state where we were primarily doing only virtual care. And so we couldn't do this sort of balanced, the people who were coming in person was a very distinct group, but we embedded that evaluation into our EPIC workflow so that certain questions like, did this visit replace an in-person visit, were forced fields that the provider had to answer before they closed the encounter, so that we can then look back and see what proportion of those visits were effective. And we asked things like, was an A1C, one of the big limitations to a virtual appointment is that you don't have that point of care A1C. So we asked questions that were forced fields within EPIC, like, did not having an A1C change your management? So even on a smaller scale, there are things that we could do within our using our digital tools to help ensure that we have this kind of learning health systems, continuous quality improvement slant on how we're prospectively gathering data so that we can evaluate.
Thanks.
All right, thank you. Before we go on, I'm going to ask Shelley to take the slides down so we can see everybody. Thank you. And there was a question that Tom Cavesi put in the chat. I think people can probably see it. I was going to ask Shelley or anyone to comment on that, but I see Shelley has responded. The question was about thoughts about an RCT for evaluating health outcomes. Is there anything else any of you want to add to that question? Or that response that Shelley posted?
I think I'm happy to just add that I agree that would be the most robust, and that was something in our scoping review, which we're just completing now. It's very clear that is lacking, and particularly because of the context of the pandemic, where you just couldn't do that because we didn't really have a choice in the way that we could deliver care. But I think that now is the perfect time. It feels like, I won't declare that the pandemic is over, but it feels like we've reached a steady state in terms of that balance. Right now, the proportion of virtual versus in-person has reached a state that I think we feel, based on our experience and based on the evidence, is most appropriate. And so I think we are at the point now where we could use that framework that Catherine presented to design RCTs to really properly evaluate. I think that would be the right way to do it.
Okay, thank you. We have two questions, first from Alessandra Rossirici and then second from Joe Reisman. Go ahead, Alessandra.
Hi, thank you very much. I think this is a wonderful study, and I'm very interested in seeing what results will come out of it. I think virtual care has definitely opened up access to a lot of families, and like you said, it's very convenient for so many families. I was wondering though, we have had some issues in the Emerge virtual care, and also reviewing some of the cases of mental health with teenagers and the lack of privacy when we're doing virtual care, and trying to have those private encounters with teenagers, and also with the transition to adult care. Do you have anything specific in your study looking at like the opinion of teenagers themselves about how they feel about the virtual care? because I think that's definitely something that we should explore a little bit more. I think it works very well for the families with younger children, but I do wonder about if sometimes we do lose a little bit of privacy and that one-on-one, face-to-face contact with adolescents.
All right, who wants that one?
I'm happy to start, and people can definitely chime in. I'm so glad you raised that, Alexander. That's certainly a huge issue, and I know that my diabetes colleagues and I can attest to the fact that it's so interesting. You know, like I said, we're ensuring that one visit per year is in person, but for the other ones, we often feel like many of those could be virtual, but the adolescents themselves largely tell us they want in person. So we're already here. I mean, part of it is missed school for sure, but I think there are other advantages as well. And one of the things that makes our framework unique, actually, in speaking with the author of the AAP framework, one of the things he really liked about ours was highlighting privacy as one of the subdomains. So I think that as that's evaluated, absolutely, we need to seek the input of the adolescents themselves in terms of getting that information. So I think it's a great point, and I think more to come in terms of getting the feedback directly from those teenagers and adolescents.
Thanks, Ellen. Leanne, are you going to respond? Are you going to add to that discussion? Okay, go ahead.
I am actually. So my son is only 12, so I can't really speak for teenagers and the experience, but as a family, I would not want all of my visits to be virtual. I think even though I see the convenience of it, that would make me very nervous. So I do really appreciate having a balance between those two things, and whether it's a privacy issue or a parent confidence issue, like it might be the perspective of the provider that we don't need an in-person, but I feel like I need that touch base every so often too. So I think that's an important component to make sure that there are all those, like maintaining some level of in-person is part of that confidence that parents need to feel. Like the other two appointments are fine virtually, but I want to see you and know that we've had that face-to-face.
Great. Yeah, so really important to bring in that flexibility and shared decision-making about, you know, which ones would be virtual, which ones would be in person. Great. Okay, back to the questions. Joe Reisman, you're up next.
Thank you, Dr. Jabbour, and thank you, Ellen and team.
I'm hearing you, Joe.
Pardon me? Can you hear me now?
Now we're hearing you, yeah.
Oh, sorry. Thank you, Ellen and team, for a great presentation. There was just a couple of points to Leanne Finley's point. If not a medical journal, but a science journal, there's a great science journalist named Lydia Demworth, who wrote a one-pager in this month's Scientific American about the very things we're talking about this morning, the acceptance of telehealth in America, that kind of thing. And it was very America-focused, but interestingly, she talks about clicks and mortar instead of bricks and mortar, clicks and mortar. And it goes to Leanne's point that part of our evaluation needs to be, how do we find the right balance between in-person that provides us the in-person kind of data and blends it with the ability to do a virtual visit as well. And I think that sophistication will come with time. I know Tom would echo my comments that in CF, for a certain cadre of patients, we found that we had a little bit more deterioration in pulmonary function tests that we would have expected if we'd seen them in person. That said, it's difficult to quantify, and it's anecdotal, but those kind of things need to be evaluated. My main point was this: as we go forward, Mona, number one, this is a very important way of highlighting CHEO's innovation and this group's and the RI's innovation in terms of how CHEO is very forward-thinking, innovative as an organization. And I can't think of a better presentation than this morning's Grand Round. So thanks to Ellen and team. Number two is this, that the physician, you know, it's all about show me the money. This thing will progress and advance if we have a way of funding it. So the 2024 PSA, Physician Services Agreement, is about to start to be negotiated. I would encourage everybody listening at this rounds to do some advocacy and send messages to the pediatric section of the OMA, to the OMA, even letters to the president saying how important support for negotiating continued government support for virtual visits should be funded. This current support is time limited. It's not really been built into the psyche of the Ministry of Health yet. Ellen rightly pointed out that certain things, that video is valued higher than telephone, that's for sure. And I would support that. I congratulate CHEO's ability to integrate virtual into the actual EPIC system, our medical records. So it's so easy to do without going through the Telehealth Ontario link. But I think we need advocacy in that domain. And so that's all I wanted to message people. Don't take this for granted. We need to put pressure on the OMA and MOH to continue this kind of work.
Joe, can we say it saves money or not? Sorry. Okay, I'll shut up.
We do have two other questions, Alex. I'm sorry. Okay. All right. Good point, Joe. And all the more reason why it's really important to have the evaluation to help us learn how to use virtual care, when to use virtual care, when not to, etc. So this evidence is really going to help inform our practices. Great. Okay. We have time for two hopefully brief questions. Rob Klassen and then Michelle Ward. Go ahead, Rob.
Yeah, I'll keep my question short. I thought it was a really good overview of this program that you're doing. It's fantastic. The one thing that I thought was missing is kind of the resource implications or the administrative side of it, because I find it, I certainly like virtual visits, but it does take more time on the physician side. But on the trade-off is that you have no nursing involvement other than setting it up or administrative setting up the actual call. So I think, there's something there that the administration, the hospital administration likes the virtual visits because you don't need a nurse for it, but the physicians, it does take a bit more time. So it's just something that would be good to capture going forward.
I think that's a really great point, Robin. I feel like some of the clinics that are sitting at maybe 20% virtual, maybe what's more appropriate is 30% for them, but they're lower because of things like that, where it is a little bit more difficult to integrate it in. It's hard to have a hybrid clinic, for example. So I agree that if we can provide more support for that type of thing, and in endocrinology, for example, we started something where when we had a pharmacy tech, we actually had them looking at the list of virtual visits and having them call the patients ahead of time. It's hard because it wasn't specifically connected to the visit, but getting into that mindset of anybody can click that link and chime in just the same way as in person. We are able to do that. It's just a matter of setting up the workflow so that it's natural for us, just like it is in person. But I totally agree.
Great, thank you. And final question to Michelle Ward. Go ahead, Michelle.
Thank you. Thanks for a great presentation. I really enjoyed that. And it's something that we've been really thinking a lot about in child maltreatment identification. But I think my comments also have relevance to a broader audience, not just in that area. So Stephanie Lim Reinders, I want to give a shout out to her. One of the pediatric residents actually led a study that was CPSP based one-time survey about identification of child maltreatment through virtual care. And we've just submitted a manuscript around that. And not surprisingly, there were benefits and concerns from pediatricians about their ability to identify child abuse concerns virtually, and about 4% of physicians identified cases where they felt there had been harm as a result of virtual care, but others seeing into the home felt that there were benefits from it as well. What I wanted to ask you about, though, was in our visits as physicians, as pediatricians, we do a lot more than what the patient is there for specifically. So they may be coming for their diabetes care and their A1C check, but we're checking in on lots of different things with the family and identifying things that they might not even be bringing to the table through our, assessment of them, our discussions with them, noticing things that might look different from other visits. So I'm wondering how you've thought about those kind of intangibles in some ways, and other things that we do in our visits beyond the primary purpose of the patient being there.
Thanks, Michelle, for that question. I think that's a great point. And actually, for our surveillance study, we have some of the same, co-investigators as were on that one-time study that you were a part of, and so are trying to carry forward some of the ideas from that. I think our hope is that with the CPSP study, we would pick up on some of those things where they present, a week later, and the reporting physician recognizes that it's something that would have been picked up in that virtual encounter if it was in person. But we don't know what we don't know. So I think that's always going to be a gap and something that's going to be really hard to measure. I don't know that I have any bright ideas about how we would do a better job measuring that. Because even from a patient satisfaction perspective, if they don't know, they're not going to know that something was missed. So open to ideas that others have about that. See, Catherine has a comment.
Thanks, Ellen. Yeah, it's just to build on that. I think if you look at the evaluation framework that we've developed, you'll see that it's quite holistic. And if we looked at our virtual care programs or care delivery programs in that broad context and consider all of those factors, in addition to sort of holistic patient strengths and needs assessment, I suspect that it would help us identify those questions and situations where virtual care is more or less appropriate. And I really feel that it would, looking at it holistically that way would allow us to come up with better, say, algorithm, for lack of a better word right now, but better algorithms for when virtual care is appropriate or more or less appropriate, and what to keep an eye out for.
Okay, great responses to the questions there, and really amazing work by the evaluation team and the 4 presenters today. So thank you very much for sharing this work with us, and we look forward to further updates and use of virtual care. So thank you again. A wonderful day, everyone.
Thank you. Bye.